First of all, I would like to thank AIOS and Satanshu sir and Subhadhi sir for having me here. So I'll be speaking about intraoperative complications and difficult scenarios. Of course, this presentation is quite basic presentation, and I prepared it for the PGs. I can see quite few of PGs here, and the young surgeons. So any difficult situation intraoperatively can land you in a complication. So I'll be discussing those basic conditions. These conditions might be quite easy for an experienced surgeon, but for a learner, for a resident, they can cause a big trouble. So in my experience of past 15 years of teaching, I've seen that there are complications at two stages in a surgeon. First, when he's a beginner, and second, a trained SICS surgeon shifted to phaco, learned phaco, and comes back to SICS for one or two odd cases, because he's more accustomed to the phaco and comes to SICS, then he's more tend to develop that complication. So what are the eyes prone for complication? High myopic eyes or high hypermetropic eyes, post-traumatic eyes, deep set eyes with sunken eyeballs, obese patient with thick neck, hard of hearing or uncooperative patients. These are the most common cases what I've seen land up in complications. So I'll be dealing with some basic complications. I won't be discussing about PCR and nucleus drop because they are most often talked in all the conferences. So first is premature entry and intraop iris prolapse. They go hand by hand. So what it leads to? It leads to premature entry leads to an unstable anterior chamber, iris trauma, and iridodialysis. And how to deal with it? If there is a premature entry, you can be managed with a tunnel in a new plane. You can go below that entry, or you can suture the point where the entry has happened premature and continue surgery with that. Then if there is a premature entry, it most often lands up in an iris prolapse. So or other side also it can land up, you can land up in iris prolapse. So first is rule out a floppy iris syndrome before surgery and try to do maximum manipulation of the side port, suture the main wound and manipulate between the wounds. Intracameral pilocarpine, sometimes it helps, and avoid overfilling the anterior chamber with viscoelastic. Stop the urge of immediately repositioning the iris. This is most important. See, in this video, the surgeon, he is repositioning the iris with a Simcoe cannula. And this is bad because this can do a trauma to the iris, this can do iridodialysis. This is not recommended. You can decompress the anterior chamber, reposition with the swiping movements. Like in the second video, here surgeon, she's repositioning with the swiping movements over the iris. Just press over the iris and swipe over it. This is the most recommended method for repositioning the iris. Then the next complication is iridodialysis. The most common steps where the iridodialysis happen while doing the main wound entry, while doing the side port entry, doing the nucleus delivery. While doing the main port entry, you can push the iris with your crescent or a kratom. While doing the nucleus prolapse, you can engage the iris, either inferior part or the superior part, and pull it with it. You can cause inferior iridodialysis, you can cause a superior iridodialysis. This is a very common iridodialysis situation in young residents. Prevention is gentle and meticulous tissue handling, and in my way of treating is I take a mecanal suture. There are different ways of, there are different methods like hangback suture or cobbler suture, but I prefer a mecanal suture for treating it. Then this is one more common complication, that is buttonholing while doing a tunnel. Now this leads to distorted tunnel anatomy and creates a leaky tunnel. So what you can do is you can just create a tunnel in a new plane again, just below that buttonholing. So that will tamponate the upper part, that is leaky part, and you can continue with the surgery itself. Then this is a common complication what I have seen in many residents, that while making the side port entry, they hit the anterior capsule because they can't judge the depth of the anterior capsule. So this is, in this case, you can see the surgeon is entering and he hits the anterior capsule. So it creates an opening in the anterior capsule. You can easily manage it by just considering that entry as a flap, and you can continue with the rhexis with the same flap, and you can continue with the surgery. Then common capsular rhexis and hypermature category milky fluid. It normally obscures the vision. Chances of capsular rhexis extension at the periphery are very high. And once that fluid seeps out from that bag, the bags becomes very lax. And because of the small nucleus, you don't have that support of capsular rhexis. So the capsular rhexis becomes difficult in these kind of situations. So you can use what you can do is you can use a capsular rhexis forceps, or you can aspirate the fluid by making a small entry into the anterior capsule, or you can do a spiral capsular rhexis before starting the main capsular rhexis. And keep the chamber inflated with viscoelastic while doing this capsular rhexis. And my way of doing it is, what I do is normally I attach the needle with the infusion bottle and do a rhexis with that. This thing keeps the chamber inflated and keeps on swiping out the fluid, whatever is coming out from the chamber. Then Argentine flex sign, fairly common. What can be done is, both the flaps of the rhexis, they can be converted into a circular rhexis, or you can do a canopter if not comfortable, because these kind of capsules are normally very fragile and they tend to extend to the periphery. Then iris prolapse to the side port. This happens when there is side port is not made properly. Now the point is that you should not push the iris from outside. What you can do is you can take a cochlear hook, or you can take a iris repositor or a dialer, and you have to pull it from the main port. You can go inside from the main port and pull the iris inside. So that is a trick here. Then inadvertent staining of the posterior capsule. For a new surgeon can be a difficult thing. The cortical aspiration becomes difficult, so you must recognize the situation and do a cortical aspiration carefully. Then localized DM detachment intraoperatively can occur due to traumatic entry or traumatic touch by instrument. So can be managed by intraoperatively by repositioning the flap with a viscoelastic and by injecting the air or bubble or gas, tempering the flap at the end of the surgery. So in this case you can see this is runaway axis, fairly common again. So first case the surgeon is not able to regain the axis. In the second case here, surgeon was able to get hold of the axis and finish the axis with the forceps. So if there is a runaway axis, you can use a forceps, or you can pull the axis towards the center to manage it. If not, then anyway you can start the axis from the other part of the other margin of the axis, and you can complete the axis that way. So other situation, small capsule axis, large nucleus. So how can you manage it? What you can do is you can give back cut incisions on in the capsular margin, but avoid giving incisions in the inferior part, because when you dial the lens inside, those incisions or those relaxing incisions, they can progress and they can go up to the periphery. So always give either in the superior part or on the sides. Then small tunnel, large nucleus, again a difficult situation. As you can see in this video, that surgeon is trying to pull the nucleus out, but it stuck in the tunnel. So you can give, in this situation, you can back incisions, or you can divide the nucleus into two parts and remove the nucleus one by one. Then intra of small pupil, I think it has already been discussed. Various modalities, the intracameral Adeline, iris hooks, pupil stretching technique, etc. They all have been discussed. This one is for cochlear hook. You can just stretch the pupil and you can complete the surgery. Then we have zonular dialysis. So it happens most commonly during the nucleus prolapse in AC because of maximum manipulation, or during the cortical aspiration. If it is less than 2 o'clock hours, you can place the lens very well in the bag, or if it is a rigid IOL or a multi-piece IOL, you can just put the haptic part in the dialysis area, or if it's more than 2 o'clock hours, you can prefer a CTR with IOL placement in the bag. So my take-home message is a thorough pre-op evaluation is a must in every case, a meticulous step-wise approach to be followed in case of complication. Complications are part and parcel of the surgery. Keep calm and never hesitate to call for help in learning stage. Thank you.